Well, welcome everybody. My name is Robert Cheney. I'm pulmonary.
Rapid response, Mountain Dew pre-op. Rapid response, Mountain Dew pre-op.
All right, we're going to put a pin on that. If I run out of here, you know.
Mountain Dew pre-op. Rapid response, Mountain Dew pre-op.
So like I was saying, I was rudely interrupted with somebody else's emergency. My name is Robert Cheney. I'm a pulmonary critical care doctor. I've worked here at Idaho community for about 2 years now. I see a lot of familiar faces. Probably apologies to those who I know, and apologies now to those who are meeting me. So I'm as pleased as punch to be here to talk about this topic. We'll see how pleased you are that you came. If you get nothing out of this, at least you got lunch. So what we're going to end up talking about today is some common problems that we have in the ICU, the complicated patients that we treat, complicated problems. We're going to talk about it from the perspective of a case presentation. Throughout the course of this case presentation, we're going to talk about the rationale, the thought process of how we engage the problems that we encounter, and we build an idea about what exactly we're up against based on things like education, experience, and things like that. So, with that, we're going to talk about shock, hypoxemia, and lung monsters. The lung monsters is a variable that doesn't happen every day. The shock and hypoxemia is commonplace in the ICU. If I use terminology that you're not familiar with, it's an open forum. Raise your hand and say, you know, what is this term meaning or whatnot. So we'll move on. This is an awesome movie. I can't wait to see the second one. We're talking about monsters. We'll talk about a couple of monsters. There are a few monsters. These are these monsters right here. Allegedly, those are the ones that I claim on taxes anyway. There may be more, but there are no fewer than 4. So, and we got a couple other little monsters. So, you got this little smug guy over here using every bit of that armrest, and then you got this guy here who's bucking to be the fifth of the kids to get braces, apparently. He's got a hell of a smile. He's adorable. He's my baby. So, with every talk should come at least one joke of poor taste. And since we're talking about hypoxemia, I mean, I laughed hysterically when I saw this. That might not be funny to everyone. I may go on a hit list or have to take sensitivity training. I think this is hilarious. It's not the first time I would have been threatened with sensitivity training, too, by the way. By the end of this talk, you'll be yeah, that makes total sense. So conflicts of interest in this talk, nothing to claim. So I'm on call right now. I am getting paid to be working in the hospital. I'm not getting paid to do this talk, short of whatever is in this thing, which may be ticking. I haven't checked it to see if it's dangerous or holds any flammable chemicals. I did get my images just from Google Images, other than the patient's actual images, chest imaging, which have been de-identified. So, and yeah, my mother-in-law does know why. So, like I said before, the topic of this conversation, and this can be a conversation, we can engage, this is, like I said, an open forum. You have questions, just throw them out. We're going to talk about how exactly we treat someone who is looking real bad, looking worse, and high likelihood to not live through their overall problem. So, this is who I am. I'm not going to go over this because this is really boring. This is who I am. Pulmonary critical care is a couple of fellowships after you do typically an internal medicine-based residency. Depending on how intense you make your track, you can be anywhere between 3 to 4 years. Mine was a 3-year track because I hate myself and wanted to do a lot of extra work in a short period of time. Yeah, you get done faster, but you hate your life during the entire 3 years. So that's why I stand in the delirious state that I am right now, because of the beating that I took during this time here. So, over that's all boring stuff. So, one of the things that keeps my job interesting, and it also is a curse of the job, is just having a great day, but in the back of your mind, my call day can get worse at any time. And you basically have this guillotine just perfectly positioned right over your neck, and you're just the idiot smiling in the stocks waiting to get killed. So there it was, minding my own business. And this is typically how bad days start. So, call comes in from this outside facility. They are a facility that does not treat critically ill people. They don't have a high level of complexity. I don't recall which center it was. I won't name which center it was. They were, if Idaho Falls is I tell people Idaho Falls is kind of on the edge of the frontier. And this is way into the frontier is where this person came from. So this nice gentleman from the emergency department calls me and says, hey, I got this patient, she came in, she looks bad, she's on the vent, and I can't take care of them, so I need you to do it. So she's hypoxemic, acute respiratory failure. So I've been married for a while, and so my wife tells the joke that nothing is as surprising as telling your husband something for the second time. And so as people are talking, talking to me on the phone, and they're telling me about complex stuff using complex terminology and really concerning contexts and things like that, but they say things, and I start to think to myself, that's funny, I wonder what was the cause of that. And they're rambling in this ear, and I'm just thinking of other things and trying to pay attention. And they probably get frustrated with me because I have to reiterate what they've already told me. I say, what about this? I said, I already told you about that, that was that. And I say, I've been married for a long time. So I have to ask myself, as he's talking to me, he says this person is hypoxemic. And the factor there is it was a primary singly lung problem that actually made them become the need for mechanical ventilation. So I start to say, well, let's build a list inside my head. What do I think this person's going to say next, and what kinds of things do I think I'm up against? So to understand the process of oxygenation of the blood, we think of the context of oxygenation, ventilation, and what are the key features, factors, anatomy, and physiology that go into that kind of thing. So this drawing I pirated from Google Images. I don't think I have a credit there. They can hunt me down and put me in jail for something or whatever. That's okay. It'd be a vacation long. So the easiest way over the course of my education and training to build lists, to make lists of things that cause stuff to happen, is to imagine from a respiratory standpoint this unit right here. So for those that don't know what this is the end of the line when it comes to breathing. So you've got this, and this thing does work, doesn't it? So this thing is called a respiratory bronchiole. This is, you imagine your lungs are like broccoli. It's fatter stems, slightly smaller stems, and then buds. And that's exactly how your lung tissue actually is. So this is the end of the line. Now we've gotten out here to the buds. Air is coming from this way, coming down this tube. Inside this sac here, this is called an alveolus or acinus. My mom's not here to say watch your mouth. But around that is this thing called a perialveolar, so this is alveolus, perialveolar capillary network. If you can imagine this end of the blood, actually let's do this because they already got an arrow in there. This end of this blood vessel is connected to the right side of the heart that's pumping blood to the lungs. This end of the blood vessel is going to the left side of the heart to be pumped out to the rest of the body. These things, the factors that influence this unit right here, help you build a list of what causes people to have hypoxemia, why they can't ventilate, get rid of CO2, and why they need ventilators, extra oxygen, and everything in between. So this little fundamental unit has got me out of a lot of hang-ups and has allowed me to have a good imagination to build lists of what's wrong with people, besides sometimes the obvious of what's wrong with people. So, much similar, this is my drawing right here. It looks exactly like the previous one. This is for sale, if anybody would like it. But the one thing I added on top of this is this little thing right here, this little Nike swoosh, and this is the diaphragm, which was not included in that last drawing. So we're gonna have a little bit of fun with some of our time today. Some of the respiratory students that are in the room have actually seen this drawing before, and they're like, oh man, is this the same thing in lecture? And the answer is, yeah, kind of. So when we're building a list of the things that influence oxygenation, we have to think, well, what are the factors, what are the components, what are the factors that are involved in breathing, what are the components of air? So one of the things is ambient oxygen. Are you in Death Valley, or are you in like the Dead Sea, or are you on Kilimanjaro? Because depending on where you are, it depends on how much oxygen, how much of the air you breathe actually has an oxygen component to it. So we have to think about that kind of thing. Are they hypoxemic because they're on Kilimanjaro? Maybe. They're a lot more fit than I am, I guess, barely. So neurologic issues. So you have to be able to breathe, right? So the thing that helps us breathe is a brain. That brain's connected to a nerve, this thing called a phrenic nerve right here. That phrenic nerve implants on the diaphragm. And if you have an interruption anywhere in the line from the command and control center all the way through that nerve and then to your diaphragm, then you can't breathe. So we talk about things like obtundation. So that's people who are high or really drunk. Or they might just be so toxic from some metabolic process that they can't think properly. Phrenic nerve paralysis. If you go see, I'm going to throw chiropractors under the bus. If you're a chiropractor or married to one, I don't know, so you can send me some hate mail. But if you get like a neck manipulation, you can actually cause compression of your phrenic nerve, and you can cause your diaphragm to become dysfunctional. I've had this happen before. Luckily, we were able to fix it. Phrenic nerve paralysis, conditions called neuromuscular disorders. These are things like Guillain-Barré disease, myasthenia gravis, ALS, Lambert myasthenic syndrome. These are syndromes that affect the way that the nerve conduction actually implants on the diaphragm, thereby telling it to go up and down and cause that respiratory cycle. Airway obstruction. So if you've got this tube, this is the end of the line, like I said, that the respiratory bronchiole, the alveolar sac, I don't know why I'm explaining this, is plainly obvious to you after that previous one. This is such an excellent that if you've got junk inside this, you can't get air through it. You can't get oxygen to diffuse out of that, to thereby get into your bloodstream. So pneumonia, aspiration stuff or whatever, drowning, all that kind of good stuff. Alveolar damage. So this area out here that's beyond the airway. So once again, pneumonia is drowning. This condition called ARDS, which is a ARDS is a qualifier of your pneumonia. If you have ARDS, it's about as bad a pneumonia as you could possibly ever, never want to have, because it comes with a very high mortality rate. Bronchiectasis, which is a long fancy word for destruction of this based on a chronic inflammatory process. This is just a completely dysfunctional alveolar unit. So another condition, pulmonary alveolar proteinosis, I'll probably never see this. It's just your body is genetically tuned to make too much protein in this area. Oxygen, air comes through here, can't make it through that protein. This is basically a dead unit right there. And other conditions that we see mostly in younger people, but can be in older people, called Goodpasture, is Wegener's disease. And that's actually an inflammatory condition that's between this here and then that there, where bleeding happens. People actually present coughing up copious amounts of blood, which is really not as glamorous as it sounds. So parenchymal inflammation is number 5 on our list here. So the parenchyma, if this is the airway, and this is the bloodstream right here, and this is the diaphragm, imagine this space that's in between the bloodstream and this alveolar sac right here, that's the parenchyma, that's the lung tissue. It's not directly involved in oxygenation, it's just this area where oxygen swims from to get inside this blood vessel, and CO2 goes the opposite direction. But if you've got something like heart failure, if you've had a heart attack or something like that, and this area is filled with fluid based on leakage of that fluid out of this blood vessel from that abnormal heart, autoimmune diseases that cause thickening of that, so this is very, very thin, and oxygen is a terrible climber, it's a terrible swimmer, and if you've got a big, thick, dense area of lung tissue between these things, it actually can't make it through. Interstitial lung disease is just a generalized term for inflammatory processes that affect that. We don't have to delate that too much. Another condition called sarcoidosis, which is also just something that can affect large portions of your lung and affect the way that you actually get oxygen out there. So cardiovascular. So this is the lung is not an island of itself as far as breathing, and we already talked about how the diaphragm and the nerve conduction out of the brain is an important part. But if you've got anywhere that's a problem inside this bloodstream right here, or the heart that's, there's a bit of heart connected over here as a sender, there's a bit of heart over here as a receiver. If you've got a problem anywhere in that line, heart failure, heart attack, or if you've got a blood clot someplace in here, these are things that will affect your ability to oxygenate too. This is a dead unit. It has oxygen coming through, but it has no what's called perfusion, meaning blood flow going to it. If there's no blood flow, there's no oxygenated blood. It's then the really nerdy stuff, and this stuff actually kind of interests me quite. I'm quite the nerd. But things like anemia. If you're low on red blood cells, then you have no oxygen carrying capacity. If you've got things called hemoglobinopathies, so sickle cell disease is one of those problems. If you can't actually get oxygen to bind to your hemoglobin unit inside your red blood cells, you will be hypoxemic. Thalassemias go along the same line as the structure of the actual red blood cell is not amenable for oxygen to be able to get inside their sickle cell. And then red blood cell fragility, meaning that you might have someone who has a problem with synthesizing red blood cells based on a genetic disorder or whatnot, and that red blood cell actually just, a large portion of them may just pop. They can't carry oxygen if they're dead. So as this gentleman's rambling on, I thought, okay, maybe I should probably start paying attention now. So I built a little bit of a list of possibilities, some of the factors that go into breathing, some of the variables. So the patient herself is this 22-year-old female, just got off an airplane, probably like within the last couple hours. This is in mid-Idaho. I don't know where she flew into, if she came from Boise or whatnot, but it was only a few hours from the time she landed to the time she came to the ED. But she was very, very uncomfortable once she got there. And the ED people look at her and they say, well, you don't look too good. And they try to do things to not put you on a ventilator, put you on some extra oxygen, see how you tolerate that kind of thing. She didn't tolerate it, and stick her on a ventilator to be able to make up for the difference between her ability to breathe spontaneously and then to try to make up for whatever else was going on inside the chest. What he tells me is that he got an x-ray after he got the endotracheal tube placed. The tube is in good position, meaning it's not sticking down into one part of, if you stick the tube, the breathing tube, and it goes over here, you've got a lung that's going to pop and a lung that's not going to have anything going into it, so that's not going to make anything better. And he didn't order any other imaging, just that chest x-ray, and he says, hey, catch, this lady's coming your way. I have questions. I think to myself. And so if you pool probably, I don't know, like 100, who are the dumbest people on the face of the earth? Let's say like a second semester medical student. Really, really dumb. Of course I'm kidding. I'm sure their moms are proud. But if you pull that group of people and you say you have someone who just had a prolonged episode of travel, a prolonged episode of immobility, and all of a sudden they can't breathe, what would come to mind? And probably like, I don't know, 82% of those people would say, oh, I think I've got a pretty good idea what's going on. And if the medical student thinks of it, the emergency room doctor should probably think of it too. Right. What it leads me to do is this thing right here, like, come on, bro, come on, seriously. You got to do something else other than say catch. I'm sure you're an excellent quarterback. I'm a terrible receiver. I'm more of like a hand to lead the ball, and I'll try to do what I can. So the worry you have is a gigantic pulmonary embolism there. And so the issue there is if this person, 22-year-olds, don't die. It's hard to kill them. I know, because I've tried. And if you have someone that's looking as bad as she was looking, she's got a big problem. And if you've got a big clot, that can kill you, because this is blood flow obstruction. You've got a heart over here, the right side, for those who aren't aware of the anatomy, and I'm not trying to be condescending to those who do know the anatomy. The right side of the heart pumps blood to the lungs, the left side of the blood receives it and is able to forcefully eject it to the rest of the body. The issue is that the right side of the heart that is pumping the blood through the lungs is kind of a sissy. It doesn't lift a lot of weights. It's a low pressure system, very thin muscle tissue. It's not used to pushing very heavily. If you've got a big clot here, that's a lot of pressure for that ventricle to push against, and then your heart stops, and you die. And there's nothing you can do, there's no amount of chest compressions you can do if you have an obstruction here of blood coming out there. Chest compressions don't make clots go away. So he should have thought about something like that. And so I'm like, hey, Brute, how about snapping a chest CT angio, make sure she's not going to die while she's in flight? And he says, oh yeah, I was going to do that. Sure you were. I know, I'm sure you were. So he says, I'll do it. Caveat, there's a helicopter inbound. And I said, have them wait for the CT. This is important. And he says, okay, oh, by the way, one thing about CTs, this young lady, while she was in Peru, had been hospitalized for several weeks for a breathing-related problem. And to which I think, now you're telling me about this? And he says, I think that she told the translator that she had a lung cyst, and that they were going to do a surgical procedure on this lung cyst, but she was too anemic to undergo it. So I'm like, how much more can you dump on my plate than this? I mean, come on, I need some information. And so I said, that's fine. Get the CT chest, I'll deal with it. There's a rumor going around that I see sick people. Just make sure she doesn't need something else. So, as I'm sitting there contemplating, the phone call's over, he's doing his thing, I'm still trying to see patients in a pretty busy ICU, and I'm still trying to build my list about what affects people. And so, if you're 22, you're young. If you're 10 years older than me in medical terms, I think you're still young. Young people do stupid stuff, and they also have unfortunate stuff. sex, drugs, rock and roll, and autoimmune disease are at the top of my differential diagnosis building for problems in young people. And I'm right probably like 82% of the time. Probably one of those things. And then the other 18% is regular boring stuff. So the other issue is that this lady, she ain't local. And so we have a saying in medicine that you don't go, in America, we have horses, meaning we have horse diseases. You don't go looking for, this next one, zebras. Unless you're my friend from training who is from Kenya and he raises his hand when people say that and they say, shut up. But she's coming from a land where, hey, they don't have, I understand, I'm aware of geography, they don't have zebras in Peru or whatever, but the case being that they have diseases that we don't have here. And so that makes it harder on a schmuck guy who was raised in the Mountain West to really start digging deep into my knowledge base into what affects people from other countries and what do I need to rule out. So he says she's got cysts. That's not helpful because the list of things that cause, this is a very small non-complete list of things that cause cysts. So Langerhans cell, histiocytosis, HIV causes lung cysts. I have no qualifier of what the cyst actually is too. And each one of these things is, if you look at the cyst, you're like, I don't know, that kind of looks like Bert Hogg debate. But cystic fibroid histiocytic tumors, Sjogren's syndrome, tuberculosis is endemic in Peru. And if you have a necrotic tuberculosis infection, that will turn into more of a cavity than a cyst, but people's vocabulary is not exactly very eloquent sometimes when they're talking about this kind of stuff. And he's an emergency room doctor, so he barely speaks English anyway. I'm only like 75%. So emphysema will cause cysts. Well, she's pretty young for your standard fares for emphysema, but still possibilities. Going along the lines of rheumatologic disease, necrobiotic nodules. She's young enough to have rheumatoid arthritis. That's part of that autoimmune disease and the sex, drugs, and rock and roll. Pneumatoceles is just a non-specific weakness in the lung tissue that can come from infection or who knows what. You can even have these things, there's just pockets of no tissue, and if you play trombone, you can get one of these things. I saw a kid one time in clinic, and he was a kid, he was like 16, and he was having recurrent popped lungs, pneumothorax. And nobody could get to the bottom of it. And I said, do you play an instrument? And no kidding, he says, yeah, I play the tuba. I'm like, you can't play tuba anymore. He says, no, I'm gonna play tuba. And I said, you're on your own then, pal. We'll see how that works out for you. Lymphoid interstitial pneumonia. And then the other one too, in addition to tuberculosis, is this 5,000 point word on Scrabble, lymphangiolomyomatosis. This is a cystic lung disease that is seen in childbearing age females. The people present with that condition in respiratory distress because they probably have a popped lung. The bad news is, while they are young, and it's hard to kill young people, the chances of living through lymphangiolomyomatosis on the term of a couple of years is very, very low. You can even transplant lungs in them and they'll still die of the condition because it'll come back inside someone else's lungs that were donated to you. So these are a list of the things I'm thinking. I may have even written them on a sheet of paper as I'm contemplating it. I can't remember. So he calls back and he says she's in the air. She's on the helicopter. She's heading there that way. Hey, good news. She doesn't have a pulmonary embolism. I'm like, yes, I'll work. But the chest CT did show a cyst. A cyst. And that's the only qualifier that he actually gave me in the whole conversation. It's just one cyst. He didn't say a big one. Like a small one, you know, it doesn't say it's got fluid in it or anything like that. And he says, hey, we share the same radiology system as you. You should be able to see that image on PACS. And I say, okay. So I go over and I sit down at my little computer and I pull up her information so I can see the imaging. A good example of normal is good. It's just fun with words. This is what a normal slice of a CT. This is a CT image, not a chest X-ray. You can tell by how elaborate all the markings are here like that. Normal heart, normal trachea, normal lung tissue, normal blood vessels coming on out here, normal diaphragm. You can see a little bit of liver, you see some stomach and some spleen over there too. It's beautiful, looks perfect. And the image I look at looks like that. That looks like there's more than a cyst going on in that image. So this is about the time where I start breathing into a bag before I get a cyst. And I start swearing in my head like, what have you done? What have you done to me? Because I know this is about to get real hard. It's going to get real hard to treat this person. I'm going to tell you, I think they're, I don't want to spoil or anything like that. So I'm thinking, you know, like what in the absolute picture is going on here. So I start to, you would say, okay, I need to find something in this. I know it's abnormal, it's called basically all of them, but is there something that is normal in there? So where is the normal lung in this? So you've got a little there, you got a little there, and everything else is non-existent. So she's running on probably, I don't know, half to 1/3 lung power here. So to describe this image to you, this right here is a gigantic fluid filled what we would call blood. And this is, like I said, these are normal. Here's her tube coming down here. This right here, the lung tissue over on the left is this, and it's completely collapsed because it's being compressed by all this fluid that's around here. And she has this thing right here. And I can't zoom in on this, but if you were actually able to zoom in on this and close, you can actually see what looks to be, I don't know, like centuries old spider webs running through this thing. And that's what's left of the lung tissue that's in that part of her lung. And then this guy down here that in everybody else in the world would be part of the stomach is still part of that lung. And her stomach is pushed way down over here by this big air-filled sac of hot misery right there. Breathing into the bag. So I look at that image. It's a fairly short flight. She lands, and all I ask of my patients is don't die within the first 15 seconds of getting to the hospital. That's all I ask you. Be as mentally boring as possible and don't die within 15 seconds into my ICU or whatnot. So she gets there and she looks bad. You know, duh, looking back at that last image, how much worse could that look? Well, she looks real bad. So she's on the ventilator. FiO2 is the fraction of oxygen that's being required to get her oxygenated. We're breathing 21% here, so she's requiring 5 times the concentration of oxygen just to barely get the job done. Her heart is pumping away. She's under a lot of distress. Her heart is trying to make up with blood flow that it can't make up for with oxygenation out of a bunch of dysfunctional lung tissue. Trying to force some blood through there. Her blood pressure is low. I mean, 22-year-old female, this isn't that abnormal for her. The fact that it's actually getting worse is really concerning to me. And then one of the concerning factors that's an old school doctor thing is what do their extremities look like? And once upon a time when I was a younger buck in training, like, what do the extremities look like? I don't give a crap. I've got all kinds of machines and labs and catheters, all kinds of things like that. Her extremities are cool, meaning her body is trying to centralize her blood flow. It's prioritizing blood flow to her core, trying to get her organs what they actually need. And that's a bad sign to me in context with this, with that, and that's really, really bad. So, now I've got a new diagnosis. This is where we start building our we've already kind of talked about building a list of what the contributors are to things like hypoxemia. She's now got a worsened condition. She's got shock. So she's actually been given multiple liters of fluid to try to trick her system into thinking it's completely happy with this situation. And it's not doing anything really. Her blood pressure is still going down. So with that diagnosis, I think to myself, what kind of shock does she actually have? Because shock is not shock. Shock is the name of the book, and the chapters are the individual causes of shock. But each one of those is very specific about the way you actually have to treat them. To treat, Z, well, you should be treating B is to say, hey, pick out a casket. So classifications of shock. So we have things, the most common one that we see in the ICU is this one, it's a slashy. It's a septic and distributed. This is a normal physiologic response to systemic inflammation. Your blood vessels are supposed to be watertight. Your immune system, by and large, actually lives in the wall of your blood vessels. When you're infected or inflamed with something, your inflammatory cells receive a signal that says mobilize and fight. This is a call to arms. As part of that call to arms, those watertight blood vessels develop slits in them. So then your immune system can roll on out of there. It's called rolling adhesion. When your when your white blood cells crawl out, and they're going to go look for somebody to fight. It's body-wide. It's not just restricted to an arm or whatever. This is body-wide. The problem with that is that where your immune system goes, now you've got slits and something that's supposed to be watertight, and I'm aware of leaky pipes. right? So you start to leak fluid everywhere. And that's why if you've ever seen anybody that's truly, truly sick in an ICU, they look like a tick that's about to bust. So this fluid is just building up everywhere, and you have to sustain their blood pressure, otherwise their organs are going to start dying. So you say that there's an abnormal distribution of body fluid based on a septic response. Cardiogenic shock. So this is your classic heart attack type situation. If your ventricles can't pump because you've got something like coronary artery disease, you're having a heart attack, the blood vessels that serve the heart are obstructed with plaque or platelets or whatever else, and that ventricle is saying, I can't squeeze if I don't got fuel, you're not going to have any blood pressure generated. That ventricle is going to become static, and that person's not long for the world. Neurogenic. So the command and control center is buku importante, if you didn't really know. This is also a lesson in languages, apparently. If your command and control center that regulates things like heart rate and blood vessel tone, meaning how wide are things, how leaky might be, how do you regulate blood pressure down here when you need to do something that's slightly different up here? If the command and control structure is out of the game, you lose, you can have some consequences with proper perfusion or blood delivery to your organs, and then be in a relative state of shock. Obstructive shock. So going back to our picture of that person that has that big pulmonary embolism there, the heart has adequate blood flow, it has adequate oxygenation, it has adequate fuel, it just has this stuff that's in the way of the blood coming out of it. That blood flow is obstructed. If you can't get blood flow out of the heart, then you have no blood pressure. So we have term this as a spectrum of obstructive shock. If the person has something like she's coming out of Peru and she's got tuberculosis, sometimes tuberculosis will cause what's called a tuberculoid pericardial effusion. So you have a little sac around your heart that's supposed to have just a tiny bit of fluid in there. Tuberculosis can inflame that, cause that to be a big glob of fluid, and that fluid can compress your heart, and your heart actually can't fill with blood to then contract, and that's a form of an obstructive shock. And then you have the boring, like anaphylactic stuff, where the bee stings you. You have like I don't know, like some ahi or whatever. We talked about, and there's air. We talked about scromberoid the other day, another fun word. So you have an inflammatory response to something non-infectious. Your body doesn't like it. So when we talk about shocks, we have to have some kind of guidance. What do we do? How do we treat these things? What do we think it is? How do we treat it? What steps should we take? How do we make these governmental regulating plague bodies happy with checking all the boxes and things like that? So we have some stuff that's been posted over the course of the years. They say you should probably do these kinds of things because when we did these things, the people didn't die, and we should probably help people not die. So, now that we've gone over, I've got an idea. I said, I think I know. By this time, I think I know the thing that's causing her to be shocked. Looking at the CT, putting some physiology together, what's the biggest risk for her to have a particular form of shock? I think I know. The problem is that in order to treat that shock, I have to give her chemicals that are so toxic that if it were to go inside a peripheral IV and leak into your skin, your muscle, you may need to have your arm amputated. I mean, this is like big gun stuff. Had a poor lady up in the ICU several months back. She was emergently transferred to the ICU, low blood pressure, progressively septic. She was getting some of these medications through a peripheral IV. It leaked. She had to have her arm flayed open by a surgeon to get all of the dead stuff out of it because this stuff leaked in there. It causes tissue necrosis is the word. So she needs blood pressure support. So we got tools, we can do stuff to people in the ICU, and hopefully we can do it fast. So we get our ultrasound, and we get this set up right here, and I stick that right in her neck. So use an ultrasound to find the anterior jugular vein, put this needle on that thing right there, and stick it into her neck, and then feed this thing, which is a wire that goes down through here, and that wire goes all the way from the neck, all the way down into the heart. If you push it too far, the nurses say things like, you pushed it too far. and you pull it back, because the heart doesn't like to be messed with. And if it's poked with stuff, your heart will object. And so you say, yeah, and you pull it back out of there a little farther. And then you slide this thing over the top of it, and then you stitch it into place. And through this, we can put nasty, nasty stuff. And it's because we can put it through this into the jugular, because now we're diluting all of that stuff inside big blood volumes and stuff like that. So it will, excuse me, it'll work, and you won't have to have your head amputated if it leaks or something like that. So she needs blood pressure support. What kind of blood pressure support? We've got multiple different medications that we can actually use. And usually about this time, as I'm breathing into the paper bag, I'll run over and ask my favorite pharmacist or whatever it's like, tell me what to do. And they're always full of good ideas. Our pharmacists are the ones running the ICU, BTW, at least where I'm on. And so we have things like medications like norepinephrine. We have things like dopamine. I love dopamine. It's fallen out of favor, it's coming back into favor, and I'm going to tell people that I was stylish before it was stylish again. And so I use more dopamine than a lot of people do, probably. Vasopressin, epinephrine. This is adrenaline. If you hear anybody say, give them a shot of adrenaline, adrenaline's a trade name for epinephrine. Phenylephrine, we have this other new stuff that costs a lot of money. And then when I use this kind of stuff, the same pharmacist that I asked for the guidance of just goes, all right, because it's expensive. And if you're using this, usually the person is really high risk of not making it, so then that's a lot of expenditure. So to understand which one of those medications, this is my thought process as I'm going through these kinds of things. What's wrong with the person? What can I do for it? What kind of medications can I use, and which ones are going to be most efficacious based on the way that they actually work? This is a thought process that we have to think through with each of these people. So we talk about mechanisms of action. I'm a huge nerd when it comes to mechanisms. When I was in medical school, I used to make all my attendings angry because I'd say things like, what's the mechanism behind that? They'd say, just read a book. So I ended up reading a lot of books. So norepinephrine, and this is kind of the quick and dirty of it. You want vasoconstriction. You want those dilated, leaky blood vessels to come back into some semblance of what they were. To constrict them is to cause better flow to go through them, to get your organs the things that they need. It has a very, very small ability to either make your heart rate a little bit higher or to make your heart rate lower. You really don't know what it's going to do. But you're looking for it to make the blood pressure go up. It's usually a first-line medication and everything. According to one of those papers we looked at, it's called the Surviving Sepsis Campaign. So the norepinephrine is a go-to in shock of particular sorts. A vasopressin, this is another one that causes constriction and increased blood pressure. It's very selective about where it actually works, and it also helps you limit how much of this you actually have to give, because this stuff will make your fingertips pop off, your toes pop off, your tips of your ears turn blue, your nose will turn blue. People start looking like they've got leprosy when they are in high doses of these medications. The very, very small capillaries at the end of those places, if you constrict anything there, then they don't have any blood flow, and then the body doesn't need it if it dies. And so if it doesn't get blood flow, it dies. The body doesn't need it, it will get rid of it. So they will fall off. Epinephrine, adrenaline, so that'll boost your heart rate like crazy. It has some ability to make those blood vessels tighter, and it can augment the strength at which your heart actually contracts. So we call that cardiac output between the heart rate and the heart squeeze. And they get a higher cardiac output. Phenylephrine is another one that I use fairly often, and it doesn't have any other really effects other than it increases your blood pressure by making your blood vessels smaller. Dopamine is the oldie but goodie. It can increase your heart rate, it can augment your squeeze, because of vasoconstriction. It's a lot like epinephrine. And then angiotensin 2 is a fairly new drug. I think it came to market probably in the last 6 years or so. It's expensive for that reason. It's used as what's called a salvage vasopressor. Vasopressor is another word term for a medication that causes vasoconstriction or something that raises blood pressure. Oftentimes you're adding angiotensin 2. It's Giapreza. It's Giapreza, right? We're there now. Yeah, okay. I have my brain doesn't work right now. See, pharmacy. Everybody clap for pharmacy. Giapreza, which makes it sound like it's some kind of like sweet treat or something like that. But it's usually used later on in the course. If you're using angiotensin 2 on somebody, they're probably not going to live, honestly. I mean, from what I've seen, some people will use it fairly early. I use it as salvage therapy. It's a last-ditch effort to get people to live. I don't have good luck with that. I'm pretty sure Aaron agrees. I'm going to look over and see if he's nodding, but I think he agrees. So she gets these medications. We pick a cocktail of these medications. She's got this big fat catheter in her neck now. She's on a ventilator. I'm trying to optimize what we can do with the ventilator to oxygenate her and then get her some circulation too. Despite these efforts, she's actually getting worse. Not a bad sign for me. I need 2 paper bags to breathe into at that point. So like I said, so we put these things in there. I pick norepinephrine and vasopressin to start with. Blood pressures are still getting worse. She adds a 3rd and a 4th line vasopressor on there. I'm like, this is 100% salvage at this point. How we're going to keep her alive. This is the point where if I'm doing something, I look up at whoever's across from me and I say, get the crash cart because this person's about to die. And so we need to have like the paddles and all that kind of stuff, paddles. They need to get all kinds of nasty stuff done to her. Her oxygenation is getting worse. She's on 100%. Like I give 110% as only in sports because you cannot give 110% of oxygen. It just doesn't exist. Her coloration, her extremities are colder. She's turning blue basically, and this is very, very bad. This is another joke in poor taste because that's what I specialize in. If your body's normal compensatory response to stress is to have a high heart rate. A high heart rate is to maintain cardiac output. That is, high heart rate it's very good in the short term, it's very bad in the long term. But if you're so sick that your heart rate starts dropping, that person's really about to die. And very sweetly, a nursing student, I don't want to pick on nursing students, but just pick on nurses in general, and they know why too. The very sweet nursing student says, yeah, everything's getting worse, but at least her heart rate's not as high. And everybody who knows anything in the room all kind of did that forehead slap because this person's about to die. So it's time to get fast and furious because she's getting worse and she needs more stuff. This is where critical care comes in. You have to know science and you have to be a bit of a surgeon too. You have to be a proceduralist. And sometimes if you can't heal with medicine, you gotta heal with steel, and she needs some steel. So, what's going on with this lady? At the time, I'm pretty sure I know what's going on, but it's always good to reflect. So that, if you remember, I guess not to jump ahead of myself, her imaging tells me actually what's wrong with her. Her risks, her oncoming symptoms, and just that constellation of other problems says a couple different things. Maybe she's got a big pulmonary embolism with some ongoing heart failure. She already had the CT angiogram. That's probably not likely, but that would probably be right 92.78% of the time. Heart attack, sex, drugs, rock and roll, and some cocaine in there, whatever. Yeah, they have heart attacks, but she's not having a heart attack. There's nothing, she's young, there's nothing that looks like a heart attack on monitor besides that her whole system is failing. You get over the whole system failing thing, everything's great. The other thing is tension pneumothorax, which is actually when you start filling the chest cavity with air through a defect in the lung. Your lung collapses, but your chest fills with air and continues to fill with air dynamically, meaning it's worse moment to moment to moment. And now you've got air collecting in part of your chest that's now compressing your cardiac structures. And your heart can't move and it can't pump blood out. It cannot work in that kind of environment. We call that tension physiology. There's just, the heart is completely displaced in some of those people. Well, on her imaging, she did not have a pneumothorax, being that she had air around her lung, but she had a gigantic bleb right there at the base of her lung. And I can put 2 and 2 together and say, I think she's at risk of tension pneumothorax through a different reason. So, what's going on? I think this is a spectrum of this. So, the issue there is that going back to that bleb, the other thing on that image was an endotracheal tube. That endotracheal tube is providing a pressurized column of air that is hoping to expand the lungs. If you're aware of the path of least resistance, when you're talking about expanding and all that inflamed gunk that was in the chest, and you're saying left road's hard work to inflate this lung, the right side of the fork over here is that wide open freeway in the form of that pocket down there. And so air is going to go the path of least resistance. And now what you've got is a dissecting, lung dissection basically. So that pocket of air that's in there is being dynamically filled with air, and it's just tearing that lung tissue to shreds. Anything that's in there is being just completely obliterated by that pressurized column of air. And it's expanding to the point where it's actually shoving her cardiac structures to the opposing side. Well, I don't have time to get an x-ray to prove it because she's about to die. So I'd say, what do I have available? So if you can't heal with medicine, then you heal with steel. So I get a couple of things here. I get one of those, and I get one of those, and I've got something that looks like that right here. And I can get one of these things right here that are, these things called chest tubes. And I make a hole in her chest. And I say, I'm going to alleviate that air, that pressure that's building in there, and I'm going to bring her back from death. So I take that scalpel, and I basically cut her from probably about, I don't know, about like that wide or so. Get a good incision in there. Then I take these things right here, and I dissect down through her skin, through the fat tissue, through the subcutaneous tissue, all the way to where you can see her ribs. And then I take that there, and I find a spot over the rib, and I shove it through it. Stab her straight to the side, through the muscle. And then I take those things that are nicely closed right there, and I open them, and I rotate them, and I open that pocket. And things happen when you do those kinds of things. If you're conscious, the person's conscious and they do it, they say like, ow, what the hell are you doing? And in her case, she's sedated. And so, but all we get is a gush of air and a bunch of fluid that ruined the pair of shoes that I had. I had to get rid of them, there's no salvaging. But all that stuff just kind of goes all over the place. And then I take this thing right here and I shove it through that hole, and I feel this thing that feels like lung, and I grab a hold of it and I wrench on it, and I tear a hole through the lung tissue, which is you should not do unless you're in this situation. So I rip a hole in the lung and I dissect it basically, and then I shove this tube through the hole that I've made, and I stitch it into place, and I connect it to a box and connect that to suction. And the suction box is just bubbling like crazy. There's a ton of air coming out of this person's chest. Well, there's not very much satisfaction we can get instantaneously in medical terms, where surgeons have more satisfaction than we do because they can heal stuff pretty fast. But from a medical standpoint, we don't get a lot of that satisfaction. But, like, we're starting to put out some fires here at this point. So after we put that chest tube in there, vital signs just rapidly improve. The heart rate comes back. She's on 4 different blood pressures to maintain adequate blood pressures. All of them come off instantaneously, and now her systolic blood pressure is over 200. Like she's at a rave or something like that. She's having a great time. So everything basically gets better all at the same time. Having said that, now we've alleviated shock is out of this picture. So our obstructive shock is probably one of the very few things that we can treat and have it resolve practically instantaneously. But she still got a crap load of hypoxemia, because those lungs ain't normal. And then somebody went in there and tore a hole through her lung, be it on purpose. If we didn't do it, she would have died. But lungs with holes in them ain't good. I read that chapter in that book early in pulmonary training. So it's at this point where we actually start to get her somewhat stabilized. And then I've got to say to myself, what else can I do here? And so I need help. You've got to know when you can't really do anything else. And so I call a cardiothoracic surgeon, and I say, here's my situation. This is what I've got. And I said, if you would like to come to the ICU, I'll show you the images. And they kind of laissez-faire about, yeah, that's cool, we'll come there. And surprisingly, they actually showed up in a timely fashion, because cardiothoracic surgery, anybody knows cardiothoracic surgery knows they're on their own time frame. They'll go get their laundry before they actually walk 5 feet to go see somebody that was just asked for it. So pick out a cardiothoracic surgery too, but they know why. So he says, yeah, I'll come and take a look at it. He looks at that chest x-ray and he says the same thing I did, like, what in the actual blankety blank is going on here? And so I'm like, I don't know, bro, I just need you to do stuff. Like, there's only so much healing with steel I need, I can do. I need you to do something. So he goes to the OR, and then he sticks a chest tube into this area right here, and then drains this fluid pocket, which is a good idea. I think it's a good idea. But he also did something, I'm like, that's a horrible idea, because then he went and he put alcohol in here. And problem being that that will clean some stuff up, but it'll also cause a massive release of if there's something infectious in there, it will release a massive amount of infectious particles systemically, and people die of septic shock then. So he said, I said, oh good. And he said, I did that. I'm like, oh, I don't know if my face showed it or not, but I wasn't super happy about that. So he went to the OR, he puts a chest tube in there, and then I end up putting additional chest tubes in. So this lady came in with 4 extremities, and now she basically looks like Spider-Man. So this is her post-procedural x-ray right here, which is still pretty ugly, but there's some good news in here. This is where that big pocket of fluid was. It's kind of hard to see some of these chest tubes. This is a big fat tube. It's coming in here, the surgeon placed, in addition to this little guy over here. This is the first one I placed. This is where that big black pocket of air, well, it's still there though, right? Because that lung's not, it won't collapse, it won't inflate. Now it's just kind of stuck where it's at. But this is actually continuously leaking inside the chest cavity, but it's not dissecting anymore. This is the problem, this thing was dissecting. But she, in radiology terms, we call all this stuff that's coming here spaghetti, and she got a lot of spaghetti. So more and more chest tubes in there. So working her up, trying to give her what support we can, and then oftentimes unprofessionally we see gross stuff. We say, ooh, that's pretty gross. Instead of, oh, that's interesting, like I was trained, I should say. So the fluid drained from that pocket that was over there, right here, is sent to pathology, because everything that's the surgery touches goes to pathology. They'll pull a kernel of corn out of something and send it to pathology. Pathology looks at it and says, it's kernel of corn. And so they send it for pathology and microbiology. This person's on all antibiotics. And then, as I'm once again minding my own business, the pathologist calls, and he's practically breathing into a paper bag. They're not very excitable people. They're usually very even-keeled. He says, I think I found something. I go, I'm on the edge of my seat. So he shows me this. So what are these things right here? Well, if you remember the opening slides, that big dune worm, these are worms. And so looking here, these are worm teeth. This is a worm head. These are things, this is called, altogether this is called a scolex. And so they have these little cysts that are in them, and this thing's in there just having a great time. And who knows, yeah, that's the one. And so who knows how long that thing had actually been in there. It's very hard to temporally, estimate how long that had actually been in there. But, it's times like this where I'm proud to be an American, because I'm not kidding. We have a diagnosis now. So now we have a kind of coccal cystic lung disease. So talk a little bit about, so now we've shifted from one of those first slides. It says that ICU doctors actually in a lot of ways have to be a jack of all trades. You have to be a cardiologist, and it's, I'm sure they're bored with it up in the ICU, but I'll say things like, they're like, do you think we need cardiology? And I'll say, well, I'm at least an amateur cardiologist. I could probably handle this thing. Or I'm an amateur nephrologist, yada, yada, yada. But you've also got to say, okay, I'm in this treatment, but I also have to know the spectrum of disease activity, and I have to know what types of bugs respond to what kind of drugs. And so this is our mug shot of what these things actually look like if you were to have one in a whole specimen. Then this is a scanning electron micrograph of one. But it's not exactly, it's not something I want. I'm not going to judge you harshly, or too harshly if you think you want something like this, but these things, this will implant, hold its spot there. These things right here get all your blood out of it. So while it's holding all this is the thing that's sucking out of there. Just a couple different side profiles. So the particulars of this particular problem. So this is a type of a tapeworm called a Echinococcus. And so there are two more typical presentations or clinical manifestations of this particular issue. One is really rare. For the sake of time, I skipped that one. Let's talk about this other one here. So these things are a form of tapeworm, like I said, anywhere between 2 to 7 millimeters when they're recovered. This isn't when they're in like little baby size ones, but they're usually transmitted by dogs who are what's called a definitive host, meaning that's actually where they want to live. And then their opportunistic hosts are poor 22-year-old females from Peru and farm animals. So when you have early in the course of your infection, I won't go over, the next slide will be, I think it's the life cycle of this whole thing. But early in the course of infection, you don't really have any symptoms. So if you get the flu or a cold, you might have a fever. And that's just a little tiny, submolecular issue there. This thing is, these things are like gross, both in nature and in size. And so you might not have any symptoms. Truth be told, with her level of abnormalities that were in her lungs, she probably had that thing for a while. And whether she had a primary infection and then had a secondary infection, or whether this was all spread of the same thing, because it was bilaterally. This was like a two-lung thing. And your lungs are actually separated by what's called your mediastinum in your chest, for the most part. I won't get into the gross pathology or the anatomy of it, but there can be some connection there, but usually not significantly. So maybe two different infections, temporally spaced. They love certain organs more than most, so the liver, lungs, very vascular places, the little sucker thing there likes places that are filled with blood. So they'll go places where they're all blood. Liver is a big sack of blood. The lungs are, I'm pretty sure they got some blood going to them too. This is the life cycle. Excuse me. So you've got the adult here, makes some eggs. Those eggs kind of grow a little bit. You've got some animals involved in here. You get a dog that makes doggy-doo. And then you get sheep who are not that bright, so they eat stuff that's contaminated with doggy-doo. And then this thing passes out of their GI tract, and then dogs are also sometimes not that bright. My dogs are pretty smart. And then humans, well, if this is like something that's actually passed in stool, well, how did she get it? That's why I'm proud to be an American. We have standards for the way that our food's processed and things like that. We call that a fecal-oral route. Those are two words that should never be together. Fecal-oral. So she ate something that had been contaminated, and it had made its way through her system, and then in her case ended up in her lungs. She may have had something in the liver, but there were no significant liver abnormalities in the lab work, things like that. And imaging, that kind of stuff would be really difficult for the liver. So we have a therapy for that. This stuff is called albendazole. I have prescribed albendazole that many times, and it's on that lady. So I just don't see this kind of stuff. So we stick her on these tablets, and we say, man, I hope it works. Meanwhile, we have a 22-year-old that's stuck on a ventilator. All those chest tubes went in all those places, and they are just bubbling away. And by that I mean there is a constant leak. The ventilator is actually giving her breaths of air, and the breaths of air are going the path of least resistance. There is the path of least resistance in the form of that big glob of dead lung, but there's also the like a super highway, and those chest tubes are on suction. So now that air is really taking the quick route out. That becomes a real problem with people on ventilators, because if the delivered breath of air is going everywhere but where it should go, the only thing you have left is to clamp those tubes, in which case you get tension physiology again unless she dies, or you have to monkey with the ventilator, and that's where we need a little bit of help from respiratory therapy, and we try to come up with a good plan to say, hey, is there anything on her ventilator where we can maximize a delivered breath so that it goes places? And so your normal physiologic breath is usually of a certain volume, and we were giving her like really high volumes of air to try to at least have some of it go to that lung tissue to oxygenate, and it was kind of working. But those chest tubes are bubbling away. That cardiothoracic surgeon, very nice gentleman to help me, he says, well, good luck. I'm coming off service and there's no one to replace me. And I'm like, okay. So what do I do with this information? I've got somebody who's a non-US national requiring intensive management, and her long-term prognosis is really in doubt. She's gonna need a lot of therapy. She's gonna need a lot of, this is not her first, these chest tubes are not her first run-in with surgery. And I know that, and he knew that too, but what are you gonna do? He didn't live here, and so he had to go elsewhere. I want her gone because there's nothing I can do. She needs to go someplace where somebody can do something for her. Otherwise, I've got somebody that I'm just pretending like I'm actually doing something for. So she needs to go elsewhere. So there was a temporary cardiothoracic surgeon that replaced the previous one, and he comes up to me one day and he's like, hey man, so I'm a cardiac surgeon, and I don't usually do a lot of thoracic stuff, and she needs a lot of thoracic stuff. do you mind if I call to see if I can get her transferred? And I'm like, yeah. Get her way on out of here, because dying 22-year-olds give me ulcers. So he's like, okay. And so he ended up calling down to IMC in Murray, and the very nice cardiothoracic people down there says, that's a very interesting case. We'll actually take her. And I said, good. Do good work. Don't screw it up, because it took a lot of work to get her this way, and I'm sure they appreciate that. So she ends up going down there and underwent bilateral pneumonectomy. Pneumonectomy is a term for cutting out lungs. Well, you can't cut out both lungs, but she went in there and had a bunch of that lung tissue cut out. And then she was actually able to have the residual good lung tissue expand enough to get the job done. So she gets that done. She has a tracheostomy for further stabilization. That's just an effort to get them off of the tube going down the throat. Requires that the person be sedated, because that's torture, having a tube down your throat and not being sedated. So you put a tracheostomy in there. It's not great, but it's better than have it down here, and you don't require really any of the sedative medications. And then we call and check on her. She's walking the halls. She's doing great. Physical therapy. She's a happy camper. I don't know where she is today. They probably gave her citizenship or something. I don't know. She requires too much. The thing about her labs is first time when she was too sick to undergo anything down in Peru, she was not anemic. They were making excuses to not actually do anything for her. She was not anemic at all. I just don't think, apparently if you can fathom, they don't have a standard of healthcare that we have here. I've actually been to Peru and their healthcare system, and it's not great, it's suboptimal. Get health insurance and get a flight if you're sick in Peru. So, any questions?
Good job.